Good day, everyone. I am Dr. Orlan Joshua Limboyugan, your instructor for today. We'll be discussing about the approach to orthopedic patients. So, for our approach, uh, there are two types of history taking that we do, one for emergency room patients and another for non emergency room patients. For emergency room patients, the priority is always to resuscitate and stabilize the patients. Data collection is only secondary. So we need to have data to properly inform the trauma team with a fast and accurate diagnosis. So the history taking is usually brief, with the chief complaint of trauma shortened to the following. So the date of injury, the time of injury, the place of injury, as well as the mechanism of injury. The time of injury is important because there we could start our patient on antibiotics on whether or not what type of antibiotics to use. For patients with spinal cord injuries, on whether or not we could start the patients on steroids. For the place of injury, it's also important because we need to take note if whether or not the patient was injured on the street, on the farm, or in any place that is dirty compared to the regular area. And of course, for the nature of injury, whether or not the force that caused the injury was strong or just trivial. So there are standard forms to fill up. We have the trauma scoring. We also have graphic drawings, which are important for medical legal cases, and also pertinent info from past medical history, family history, as well as personal and social components, like, for example, any history of drinking. So, all of these data is important and can be used in medical legal proceedings. So, you have to be very accurate. So, the PE or primary survey is done simultaneously with the history. So, we also do limb assessment secondary to ABCDE of trauma. So we usually do this fast but systematic and following from head to toe. So after splinting the extremity involved, or we're considering a fracture, so after splinting the extremity, that's when we do a radiograph. So the following are the routine trauma series that we do in all emergency room patients: cervical spine lateral, chest x-ray, and pelvis AP. So in some centers or more advanced centers, cervical spine lateral can be replaced with cervical CT scan. And of course, additional long bone views if it's practical for the patient. But if the patient has, for example, other injuries in the GI or the GU areas, then sometimes these patients are usually operated on first before being diagnosed with long bone fractures. Now, for non-emergency room patients, we usually see them on the in the OPD. They are elective, non-life threatening. History taking is usually done, and it's directed at the chief complaint of the patient. We have to be cautious because of secondary gain and family dynamic issues, especially in patients who are young or those who are mentally challenged. So the usual complaints that we do, the most common of which would be back pain or extremity pain and joint pain. Others should be limb and joint swelling, limitation of motion, difficulty walking, joint problems, a palpable mass, deformities in the limb or in the spine, as well as sports injuries. So, what to ask about the chief complaint? Of course, we have to ask about the mechanism, how the patient actually got the injury, how long the injury has been, the intensity and frequency of symptoms, what aggravates the symptoms, whether or not the patient feels the symptoms on certain positions or not, if there's associated fever, loss of appetite, anorexia, or weight loss, which might mean that there's a tumor, any loss of limb function, the effects of the problem or the chief complaint on work and activities of daily living, and of course details intervention on whether or not the patient has already consulted with another physician, what they did, whether it's medical, surgical, if they went to a physical therapist, if they went to a specialist or non-specialist, or any hilot, which is very common in our area. On the physical examination, we start with the standard head-to-toe format. We give a physical description of the back and extremities on whether or not there are any masses noted or any joint swelling. You would also take note, of course, of the neurologic examination, the joint range of motion, and any functional loss. Now, for special tests, these are specific to certain areas, and I'll be discussing them separately. Now we'll start with the special tests for the shoulder. So we have rotator cuff injuries. So what we do would be the more sensitive and specific tests for rotator cuff injuries are the following. We have the external or internal rotation test, or the lift off test, and we also have the painful arc test. Other more common tests that we usually do would be also, of course, the Job test, or the empty can test, the belly press, and the horn blower test. For patients with shoulder impingement, on the lower pictures, you'd see a positive Hawkins test, and on the right side we have the near test. Now there are a lot of YouTube videos with regards to these tests, and it's better if you familiarize yourself with these tests so that you can these tests can actually help you diagnose with some of the diseases that we usually have for orthopedics. Next test that we do is usually the Finkelstein test when we're thinking about a diagnosis of a Decker-Vein's disease. Another thing that we usually note for in the wrist would be any ganglion cyst, which would usually occur in the third or fourth compartment. Another test would be the Phelan test, and the Tinel test, and the Durkan test for carpal tunnel injuries or carpal tunnel syndromes. So the most important of which would be the Durkan test. Next test that we usually do would be the straight leg test, which is positive at 30 to 70 degrees, and it denotes a possible disc herniation. Another would be the Trendelenburg test for the hip. So usually it's positive when the patient um, cannot lift the contralateral hip or the normal hip off the ground, and the patient shifts his trunk to the normal side as an attempt to decrease the stresses across the hip. Other tests for the knee, the important ones would be the following: the Lachman test, or the anterior drawer test for the ACL. We also have the posterior drawer test for the PCL. So it's usually positive ACL when it's greater than 5 millimeters compared to the contralateral side. We also do the varus valgus test for MCL or LCL injuries. For meniscal injuries, I usually do the joint. If there's, I usually note for any joint line tenderness, because usually the Apley grind test, you do this test with the patient prone, and for the McMurray test, usually you do this with the patient supine. After the special tests, we do the preliminary imaging. Plain radiographs are always done, so it's essential to diagnose along with the history and PE. So we usually order, or we it's important to order orthogonal views for radiographs. So what we mean by orthogonal is that um, the 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 limb or the extremity is x-rayed on the anterior, and of course on the lateral aspect, so as to get a 3D view of the extremity or of the limb. So this is the characteristic of a proper x-ray. The whole bone is seen with the proximal and the distal joints, and the whole extremities in the same orientation. For the radiographs that we usually order, these are the following. So for the clavicle, we have the AP and AP cranial, the humerus, AP and lateral. Most of these are AP and lateral except for the hand and the foot. The hand, usually we order the AP and oblique as well as the foot. Other special views for the would be for the hip. We have the AP and frog leg view, and we also have for the patella we have the skyline projection, and we also have the open mouth view for the cervical spine. So these are my references. Yeah, thank you.